neonatal hemodynamics. So without further ado, we will have today a wonderful session by Dr. Caio Barbosa. Dr. Barbosa completed his residency in neonatal perinatal medicine at McGill University, followed by specialized training in neonatal hemodynamics and targeted neonatal echocardiography, along with a Master of Health Science in Medical Physiology at the University of Toronto. He is currently a staff neonatologist at the Mount Sinai Hospital in Toronto, where he's an active member of the hemodynamics team. In addition to his clinical work, he has a strong interest in advancing medical simulation as a tool for education and training, and he will be presenting today on the patent ductus arteriosus. I'll be asking all the panelists to close their camera during the presentation. What will happen is that we will have the presentation by Dr. Barbosa, which will be more didactic. Then it will be followed by a Q&A session for the entire community of the webinar. We will then close this session and we'll have a smaller group session with the panelists in order to have interactive discussion with Dr. Barbosa on the topic of patent ductus arteriosus. So on this note, Dr. Barbosa, thank you so much for taking the time to come and share with us your knowledge, your expertise, and we're looking forward for your presentation.
Thank you so much, Gabriel. Thank you, Laura, for the invitation, and thank you everybody for being here. So you should be able to my screen.
Yes, we see it well.
Perfect. All right. So I was invited to present today on the topic of hemodynamically significant PDA. So, you know, a quite not non-controversial topic. So I'll do my best, and I hope you guys join me. So I have nothing to disclose. And as we have many trainees that are joining in, I'd like to start my presentation with just a typical morning at your service. So imagine that you are a first-year neonatal perinatal fellow and that you decided to pre-round on your patients before you start your rounds. You're hoping to be a bit more efficient. We're in September. You started your training in July. So essentially, we are 3 to 4 months into the program. So you come across this case, which I'm assuming everybody had already come across at some point. So you have a 25-weeker who's now 72 hours old. He's currently intubated on minimal settings on high-frequency ventilation, had already received 1 dose of surfactant in the first day of life. And overnight, the colleague that was on duty did hear a murmur and asked for a stat echo to be done in the morning. And you have the report in your hand, and it simply says baby has a PDA. So you being curious and you're trying to present the most up-to-date management to your attending during rounds, you decide to do a quick literature check. And you simply put on PubMed, patent ductus arteriosus, you filter for the past 5 years because we want the most up-to-date information, and PubMed spits out over 2,000 results amongst opinion papers, RCTs, systematic reviews, you name it. So you can already imagine how overwhelming this would be for you to try to review all of these papers. And you decide to be a bit more efficient. Okay, so let's try to narrow it down for the past 6 months alone. And even there, we've had essentially big papers that have been published on the topic. We had the AEP clinical report on the management of patent ductus arteriosus in preterm infants. We've had an updated meta-analysis that was published in JAMA Pediatrics regarding the active treatment versus expected management of the PDA in preterm infants, along with an updated Cochrane review, also reviewing early treatment versus expected management for the hemodynamically significant PDA in our population. So I think it's fair to say that the PDA is still quite very much debated, and it might still be one of our hottest topics in the field. So the question still comes, how do these papers apply to you, and how do these papers apply to the patient that we're talking about at the bedside? Well, considering I'm talking to a group of fellows that are interested in neonatal echocardiography and hemodynamics, and this being a foundation conversation, we feel like we really have to go back to the basics in order to understand how can we apply this knowledge. So the objectives of the session today will be to review the anatomy of the PDA, the determinants of PDA closure and physiological principles, to apply echocardiography for the evaluation of the PDA and shunt volume, and to understand the natural history of the PDA in preterm infants. And while I will touch upon on management strategies, I personally hope that this will be a topic that could be best discussed in a future session, of which I can guarantee you that I will definitely be attending. So let's start back from the basics. Let's go back all the way to the fetus. Where does the ductus arteriosus comes from? So as we know, the ductus arteriosus is one out of the three shunts that allow the blood to bypass the lungs and liver, and they optimize the oxygen delivery to the fetus from the placenta. So we have the ductus venosus redirecting the oxygenated blood coming from the umbilical cord, bypassing the liver and going into the inferior vena cava. We have the foraminal valley that will direct the blood from the right atrium to the left atrium, bypassing the pulmonary circulation altogether. And we have the ductus arteriosus that connects the pulmonary artery to the descending aorta, and again, shunting the blood away from the high resistance pulmonary vasculature. So this is the important concept regarding the fetal physiology, is that we have a high pulmonary vascular resistance settings because the lungs are filled with fluid, and we have a low, systemic vascular resistance because the placenta will offer this low resistance circuit. So after birth, two big shifts occur. So once the baby starts breathing and the lungs expand, PVR drops and pulmonary blood flow increases. And at the same time that we cut the umbilical cord, we remove the low resistance placental circulation, and we would increase the systemic vascular resistance. So we know that in our preterm babies, there is a risk of ductal patency. And why is that? Well, simply put, it's related to the histological immaturity of the PDA in our preterm infants. And we can divide that into three major levels of influence: molecular, structural, and physiologic. Starting from molecular, hypoxia plays a central role, along with increased nitric oxide signaling and prostaglandin signaling, both actively promoting patency. We have also a structural issue, and here on the right-hand side of the screen, we have a quite simplified assessment of the longitudinal view of the duct, where we have a quite thin muscle cells, a quite immature layer of muscle cells, along with an insufficient number of intimal cushions, represented here by these little red dots. And we also have a relative thrombocytopenia or platelet dysfunction that would impair the platelet plug from forming and normally seal the lumen. And from a physiology standpoint, an abnormal flow pattern matter. We're going to talk about flow patterns, but in preterm infants, we know that sometimes they may have a prolonged bidirectional or right to left shunt, which would further delay the closure. But fortunately for most infants, specifically the term infants, closure will happen after birth. And once again, we can look into molecular, physiologic, and structural factors. Starting with molecular, would have a increased oxygen tension with decreased expression of vasodilating prostaglandin, along with the activation of the cytochrome P450 and increased expression of angiotensin II, bradykinins, and acetylcholine. From a physiologic standpoint, they're essentially mechanical factors with increase in SVR and decreased PVR that we mentioned, along with here, as represented in the simplified image on the right-hand side, a higher amount of a mature contractile smooth cells and more prominent intimal cushions, again represented by these little red dots, and a higher adherence of platelets to the lumen. So effectively, ductal closure occurs first by a functional constriction and then followed by an anatomic remodeling, resulting in the formation of the ligamentum arteriosum that we should have now. But in preterm infants, there's a biophysiologic contributors that would cause this imbalance between vasodilating and vasoconstricting factors, along with a delayed cardiopulmonary adaptation, an impaired response to afterload, more severe RDS, and immature oxidant defenses that will contribute to ductal patency. Now, can we assess a PDA clinically? Well, that's tricky because in the first few days of life, even a large PDA can still be quite asymptomatic. And the reason is that because of the high PVR that we have, we're going to talk about determinants of shunt volume in the next slide, but essentially if we still have a high PVR, we're not going to have that much of a shunt volume. So even in the presence of a large duct, we may not see a symptom. And as PVR drops in the first few days of life, that's when symptoms may start to present, which we might see it in the presence of a murmur, fleeting desaturations. We might see a hyperactive precordium, bounding pulses, widened pulse pressure, some oxygen difficulties, a higher number or severity of apneas, a need or an extended need for respiratory support, oliguria, or the presence of hypotension with or without acidosis. And I think it's important to also recognize how the myocardium adapts to this increased shunt that will also manifest with the symptoms. Now, these are very non-specific and quite limited in terms of sensitivity physical manifestations, because our preterm babies, they can present with any of these at any time. So from a clinical diagnosis, it's quite difficult for us to assume that a baby will have a PDA, and that's when we'll have the echocardiography to assist us in that matter. Did mention that we have to understand the determinants of shunt volume in order to understand the images that we will acquire. So what determine shunt volume? As represented here by Puzel's law, we would have the transductal pressure gradient represented by the delta P. We also would have the diameter of the duct represented by the radius to the fourth, and will also depend on the length or the architecture of the duct and the viscosity of the blood. In terms of neonatal adaptation after birth and the presence of the PDA here in this simplified schematic again on the right-hand side, where we have the right chambers, the left chambers, and your pulmonary artery and your aorta linked by a PDA. After birth, and with the decrease in pulmonary vascular resistance, you would have more blood going into the lungs, and you have a decrease in your SVR. If your PDA is still present, what will happen is that the shunt direction will change, and you'll have a duct that is now shunting left to right. If your duct persists, if your duct is still present in the days after birth, what we'll have is that we would have an increase in pulmonary blood flow, leading to an increased rise in your left atrium and your ventricular, your left ventricular preload. To accommodate this, we would see some left atrium and some left ventricle dilation. And as this cycle repeats and this shunt remains, we would start seeing more blood being drifted away from the systemic circulation, and the phenomenon that we would be referring to as the systemic steal. And that where comes the concern that we would have for compromised organ perfusion or the impaired systemic oxygen delivery. So this is just a repeat of this schematic. So this phenomena of ductal steal may present an excessive blood flow going to the lungs, presenting clinically as pulmonary congestion, pulmonary edema, worsening respiratory failure, and eventually the development of chronic lung disease. And here we would have a chest X-ray in an infant that is ventilated and has a large duct. And this chest radiograph, what is showing is an increased cardiac silhouette along with increased lung markings representing this pulmonary overcirculation. And at the same time, we would have the manifestation of decreased of systemic hyperperfusion, with compromised perfusion to the bowel, which may be manifesting as necrotizing enterocolitis, to the kidney or to the brain, as manifested classically by PVL or IVH. Now, I did put two little notes here that the papers would always refer to these symptoms as symptoms that have been observed, because the problem that we still have is the causation. Can we actually link those? The issue would be with the RCTs that we have when we talk about treatment of the PDA. Treating the PDA, we haven't been able to prove and to reduce these associated morbidities. So the causation of these effects, although makes a sense from a physiology standpoint, remains still unproven. Finally, we come to our echocardiographic assessment, because we still this is a training program for hemodynamics, and that it's important for us to take a deeper look into the whole picture. So when we're looking at the PDA, what's classically described is that you should divide into essentially three aspects. First, looking at the duct directly in terms of diameter, flow direction, and the ratio of systolic and diastolic velocities. Moving to the indices of pulmonary overcirculation or left heart pressure loading, overloading, and finally the systemic shunt effect. The first thing that we have to take in consideration when looking at the duct is that it is a 3D structure, is a tridimensional structure that we are assessing with a 2D instrument. So you may not be having the complete image of the structure itself. And on top of it all, the morphological variation of the PDA that have been described can also be a big contributor to us not having a full visualization of the duct the way that it would be intended. So the ducts have been described to have essentially six forms: the conical form, window, tubular, saccular, elongated, and the fetal type, which is the one that we would be seeing here. Types A, C, and E have been previously described in infants when they were assessing the transcatheter occlusion device. But now that we are resuscitating more and we're having more experience with our preterm babies, the fetal type is the one that we actually see in our clinical practice, which is described as a long, large, wide, and tortuous duct, and this tortuous connection to the pulmonary artery gives the appearance of a hockey stick, which I think it's quite convenient when I'm talking from Canada. So just a little quirk there. So let's go to our echocardiographic assessment, and I hope that the Zoom lag is not keeping you from seeing the image, but on the left-hand side of the screen, we have a 2D image of the ductal cut, and on the right-hand side, we have a color Doppler being applied here. But what we have to remember is that the ductus is a quite dynamic structure. And with a quite variable architecture. So while it's not possible for us to directly quantify the magnitude of the transductal flow, we would be relying on the surrogates of the pulmonary and the systemic circulations to measure them. The high parasternal view is the view that we would be using to obtain this. So the probe is placed on the sagittal fascium to the left border of the sternum, and then you would angle your probe side to side to bring the duct into view if it is present. We would assess the duct in the 2D image, as we've seen here on the right, and then we would apply the color Doppler, on the left, and then we apply the color Doppler as seen on the right to assess the direction of the flow. Conventionally and traditionally, we would be seeing a left to right flow, which would appear as red. So the flow coming from the aorta, high systemic pressure, to the pulmonary artery with would be a low pulmonary pressure. This would be the 2D assessment, where we would measure the duct at its smallest dimension at the site of the maximum constriction, and that usually would be at the pulmonary end. And we have to keep in mind that the velocity, the direction, and the volume of the shunt would be determined by the dimension, but most importantly by the shunt and the relative pressure between the two ends. And one thing that one has to notice is that the concordance between the PDA diameter and the shunt volume is quite weak, because the transductal pressure gradient is the most important determinant of shunt volume. So you may have two ducts that are quite similar in size, but they may have quite different shunt volumes depending on the gradient that it is between the pulmonary and the systemic pressures. We would then assess the velocity and the direction of the shunt by applying a pulsed or continuous wave Doppler signal in the PDA. And we may encounter essentially four types of flow patterns. We may encounter a pulsatile or a non-restrictive flow pattern, which is characterized by a high peak systolic velocity and also a high peak to end diastolic velocity ratio. We may have a restrictive left to right pattern in which we have a high systolic and a high diastolic velocity with a low peak systolic and diastolic velocity ratio. We may have a bidirectional pattern which still reflects an elevated pulmonary pressure, either equal or near to systemic. And usually this we can differentiate into two: a growing pattern in which less than 30% of the cardiac cycle is shunting right to left, or a more bidirectional, true bidirectional, where the right to left shunt occurs more than 30% of the cardiac cycle, or a full right to left, which would represent a suprasystemic pulmonary pressure. Here, I decided to put an extra inverse reinforcement in the differentiation between the pulsatile or non-restrictive left to right and a restrictive left to right shunt, and this gradient between the peak systolic and the diastolic velocity. In the pulsatile, non-restrictive, we would have a gradient between the maximum velocity of the peak systolic and the diastolic with a gradient more than 2. And in a restrictive, this ratio would be less than 2. That will close the assessment of the duct directly. But then we would look into the markers of pulmonary overcirculation. And usually what I tend to do when I'm scanning a baby so that I don't forget what I'm looking at, I tend to follow the path of the blood. If I know that my blood is returning from my pulmonary veins, that's the first part that we would assess. So we would take a look into the pulmonary veins, followed by the mitral valve. At the level of the mitral valve, we would assess the E and A velocities, the isovolumetric relaxation time. We would assess the left ventricle output. We would then do a ratio from the left atrial to the aortic root ratio. We would do the left ventricle and diastolic diameter. And we can also take a look into the left pulmonary artery systolic and diastolic velocity. So essentially, just follow the path of the blood to remind myself what abnormalities can I find with that. So these are summarized here. So PV, systolic and diastolic velocity, mitral ENA velocity and ENA ratio, isovolumic relaxation time, or VRT, LVO, LA to AO, LVED, your left pulmonary artery systolic and diastolic velocity, and if you do have a presence of a shunt, a PFO shunt, and how important that is. Because if everything is draining into the left side, having the presence of a PFO is something that can also be having an effect on your pulmonary overcirculation. So starting with your PV Doppler, we would obtain that by interrogating from the apical view your pulmonary vein, and we would assess the systolic wave, diastolic wave, and the atrial contraction wave. And although there's limited data to support this variable, what has been described is that the peak velocity cutoff of 0.5 for the D wave may be indicative of a moderate shunt. Moving on to the mitral valve E and A velocities, we'll also obtain that from the apical four-view chamber, and we would position the Doppler gate right at the mitral valve annulus, and this atrial, this E and A would refer to the early diastolic phase of the ventricular filling versus the late atrial contracting component. In premature infants, due to the immaturity of the myocardium, and there's some impairment of the diastolic performance, this ratio is usually less than 1. But in the presence of a significant PDA, this ratio would reverse, and it would be more than 1, which would be an indicative of a significance. Moving on to the isovolumic relaxation time, which is the time between the closure of the aortic valve and the opening of the mitral valve, and I hope you guys can see this. And what we observe is that the IVRT would decrease in the presence of a significant PDA. And why? Because this is related to an earlier opening of the mitral valve due to the presence of a higher left atrial pressure. And you can obtain this tracing either from a Doppler image of your mitral valve, or you can also do a TDI, a tissue Doppler image from the left ventricular posterior wall, still from the four-chamber view. And short, usually we would be referring to a time less than 30 milliseconds. In the presence of the shunt, we would expect our left ventricle output to be elevated, and we'll be using the method that was described by Kuklo and Evans. And an LVO more than 300 ml per kilo per minute will be associated with the presence of a clinical PDA. You would obtain your LVO VTI from your chamber view, and you would do your left ventricle output from your parasternal long axis view. Because we would have a high pulmonary venous return that can dilate the atrium in relationship to the aorta, we can also do the correlation of LA to AO. And we would do this from the parasternal long axis view and using the M mode to obtain this tracing. And this has been used in many clinical trials. And the clinical value that the cutoff that we have is an LA to AO of 1.5. And similarly, you can also do the LV EDD, and you would also use the parasternal long axis view, and you would put your cursor perpendicular to the septum at the tip of your mitral valve leaflets. And the normal reference range for your LV EDD have been described, and it would depend on the weight and the postnatal gestational age, and we have specific Z scores for that. And finally, you can also look for the presence of a forward pulmonary flow in diastole in your LPA, also being an indicative shunt, of indicative left to right shunt. Moving forward to markers of systemic hypoperfusion, there's usually three places that we'll be looking at. Your descending aorta, and also interrogating the peak systolic velocity and diastolic flow direction, your celiac artery, and the middle cerebral artery. So the descending aorta, you would interrogate that from the aortic arch, and the Doppler patterns that you would be expecting to find could be a forward flow in diastole, a reverse flow in diastole, which would be our indicator here of the ductal steal, the shunt steal. And also looking at the celiac trunk and SMA, you could also find the similar findings of forward diastolic flow and absent diastolic flow or reverse diastolic flow, depending on the severity of the shunt steal, similarly to your middle cerebral artery. So to summarize, because there's quite a lot there to comprise in a short period of time, you would have, again, the three parts of your PDA assessment, starting with the characteristic of your PDA with your diameter, your flow direction, and the gradient represented by the velocity in systole and diastole. Then moving to indices of pulmonary overcirculation, your LVO, your LA to AO, LVEDD, your pulmonary vein D wave velocity. And you can also look at your mitral valve E and A and RVRT, and the signs of systemic shunt effect at the aorta, celiac trunk, and MCA. There have been described how would you quantify that shunt into a small, moderate, or large, depending on the findings that you have here. And this table have been it had been quite reproduced in many papers in terms of what would we be looking at when you obtain your results. So this is essentially a summary of all of the slides that have been going on so far. When you come to assess your, if you have the presence of the Ductus arteriosus, what would you find in your echo? And what are your echographic parameters in terms of pulmonary overcirculation, along with the possible clinical associations? And similarly, what are you looking at in terms of systemic hypoperfusion and the clinical associations? What is the natural history of PDA? We're coming towards the end of the talk. I probably have 5 more minutes to close. what is the natural history? So what we know is that the incidence of the patent ductal arteriosus, so the duct not closing in babies less than 1,500 grams, varies from 18 to 77%, depending on the paper that you are referring. And it has also been described that there is a chance of 94% of spontaneous closure for babies born more than 1,000 grams before the discharge. This is a paper that was published in 2017, so it's weird for me to think that this was almost 10 years ago, when for me it almost feels like it was yesterday. That does show the PDA prevalence depending on your gestational age at birth, along with days that it would take for it to close. And essentially what we see, and because we usually deal with the most immature babies and babies that were less than 26 weeks, the mean time for ductal closure was 71 days. So what this paper was trying to show is that it would support the data of it would support the practice of a conservative management without an increase in neonatal morbidity or mortality. But the physiology behind, in terms of the overcirculation in the pulmonary, just in the pulmonary system, and the systemic, still is something that that we still have to define better. And with this, it brings us to the many different practices that we have towards the PDA management. So we have many people in the audience, and depending on your center, you may come across essentially 4 different practices. First, you may have a prophylactic approach, a prophylactic treatment. So, in a sense where you would administer COX inhibitors to all the patients within your predetermined group, the one that you want to modify within 24 hours, with the caveat that you would be exposing infants to an unnecessary medication with possible risks, to a pre-symptomatic, in which we would be as routinely screening these babies, because we know that left to right shunting can already occur after birth, and it may take a few days to manifest, as we said, quite early on. So the idea is to use echo to identify the patients with a potentially increased risk of PDA-associated morbidity. And we are quite familiar with the experience from the group in Iowa, in which they developed the Iowa PDA score that looked into the pretty much what we have described so far, and giving a score from 0, 1, and 2, and indicating treatment if the score was more than 6. And what they have been able to show is that in the most immature population, from 22 to 23 plus 6 weeks, an early diagnosis of hemodynamically significant PDA reduced the risk of death or severe BPD before 36 weeks, as compared to a historic cohort before the score was implemented. I would like to share the experience of Mount Sinai, where we practice as well with an early targeted screen, and our population that we screen is every infant less than 29 weeks. And this experience was shared at the PAS last year, and it was the real-world impact of a routine T&E screening, with the intent of decreasing intraventricular hemorrhage in extremely low gestational age newborns. So we compared the cohort after the implementation of the protocol that started in January 2023 to a historic cohort from 2021 to 2022. And what we were able to demonstrate is that an early T&E screening and targeted PDA treatment remained associated with lower IVH grade 2, all IVH, and severe IVH. And when we look into the different gestational ages, we were able to still demonstrate a lower incidence of a higher IVH grade in the post cohort after the implementation, but more significantly again in the 22 to 24 weeks cohort. You may be in a center that practices a symptomatic approach, in which you would wait for the duct to develop symptoms and then scan it and start the treatment. And it is a clinical approach that it's most likely used, but we don't have any actual evidence to support it. Or we may come to a group that it's the expectant group, which you would not act at all due to the lack of proven benefit to medical treatment. However, things that we should absolutely consider when not treating are there any additional risk factors? For instance, intrauterine inflammation, infection. How closely monitoring are we, and organ perfusion, tissue perfusion? So these babies would definitely benefit from a closer hemodynamic assessment. At the same time that we optimize their fluid management, that we assess their lung capacity with permissive hypercapnia, that we keep monitoring the standing airway pressure, we be mindful about PRBC transfusions, and at the same time that we think about the 22 to 23 weekers, which are babies that we know so little about, and we would be promoting the same way. I'm happy that Gabriel is here to also discuss about their own experience, and I trained there, so we know that McGill is a center that practices a strict non-intervention approach, and a few years back they published their experience with over 200 babies from the cohort from 2015 to 2019 with an average gestational age of 26 weeks, in which the spontaneous closure of the PDA occurred in 90% of the infants less than 26 weeks. And they were able to demonstrate that the rate of moderate to severe BPD decreased during the time period that was observed. Things that they also brought on was that the study occurred after the implementation of a new unit, with after implementation of the bubble CPAP protocols, the primary respiratory support mode, that the surfactant administration criteria was also reviewed, and the dexamethasone had been used to optimize mechanical ventilation. So when considering treatment, we always have to consider if, when, and how. We do know from historical trends, this is from the Vermont Oxford network, that across all of their sites, treatment rate in the y-axis in comparison to the year, in the x-axis into all of the modalities, pharmacologic, invasive, and combined, decreased. And we've also seen this here in Canada. These are graphs from the CNN in regards to surgical ligation and the historical trend also coming downwards for the past many years in both gestational age 23 to 26 weeks, but also 27 to 32 weeks. To highlight in regards to the pharmacological approach, there's usually 3 medications that we would be indicating. Indomethacin, that promotes ductal closure by inhibiting prostaglandin E2, and the rates of closure following its initial course varies depending on the dose, duration, and the method, ranging from 48 to 98%. Ibuprofen is a non-selective cyclooxygenase inhibitor, and acetaminophen is suspected to act on the PDA via the PGG2 by inhibiting the conversion of prostaglandin 2 to prostaglandin H2. More than 68 randomized control trials have been done in the topic of which medication is best, which regimen is the best, and so far we still have a scant evidence of benefit from prophylaxis or for treatment. And most recently, in the most updated Cochrane review, we have even the concern of possible harm, as indicated by the very early use of ibuprofen, that may lead to a moderate increase in mortality in extreme preterm infants. Procedural approach is something in regards to the surgical ligation that has been less and less used. There are many risks that can occur to it, including post-PDA ligation syndrome, vocal cord paresis, phrenic nerve palsy, thoracic scoliosis, and the inadvertent ligation of the LPA or the aorta. And the transcatheter closure is something that has been developing more and more recently. So it's an emerging option with a high technical successes rate, and it has been approved by the FDA and the FDA approved the use of the Piccolo device, the APO, for infants that were more than 700 grams. And we currently have the pivotal trial to assess further this practice. And finally, in regards to watchful waiting, there's 2 very historic papers that have 2 quite interesting conclusions. So, quoting Dr. Bennett, it would be wrong to conclude that there are no very low birth weight infants that might benefit from ductal closure. And a few years later, he said again, the absence of benefit with respect to outcomes that have been measured, because this is how we assess that. We say, oh, there's no benefit, but to the outcomes that we have assessed. So when talking about treatment, I think that I personally I still have questions. So who is the greatest who is at the greatest risk for significant morbidity related to a prolonged ductal shunt? Is waiting until an infant develop any symptoms for a significant PDA maybe too late? What about the medication risk? Are we disclosing this properly to the families whenever we expose a baby to that? And when we talk to about the procedure. So I like to close with a reflection that the delayed ductal closure, we have to always think that must be related to an underlying process, such an inflammatory response, that would delay the ductal closure and would be associated with the morbidities that are unquestionably also covariant with the PDA. And as mentioned in the most recent meta-analysis that was published just a few weeks ago, in regards to the systemic inflammatory response, what they've observed is that the PDA in the presence of preterm lung disease, it's related to the high circulating vasodilatory cytokines secondary to the pulmonary inflammation. So the preterm lung disease is not a result of the PDA, but rather the other way around. The PDA is a result of the inflammation that's happening in the lungs. And I'd like to close with a with a sentence from Dr. Carl Sagan, which was an American astronomer and quite scientifically skeptical, that said that the absence of evidence is not the evidence of absence. With that, thank you, and I think we can move on to some Q&As.
Thank you so much, Dr. Barbosa, for this fantastic review. That was a great summary of both the assessment, the impact, and the management approaches and the diversity of them and some of the controversy that are around the topic. I'm sure we'll have the opportunity for more discussions with the fellows and young faculties. We do have one question in the chat, is if you had to use these parameters in the not preterms to determine if it's hemodynamically significant, which one would be used? Or basically, are they applicable to the infants who are born more at term with, I guess, syndromes or conditions that are related to more of the congenital persistence of the duct? I think it's a great question for a cardiologist, but we'll let Dr. Barbosa try to tackle on this.
I think looking at the question, I think that what I say again, the population, and again, I'm reflecting my practice here at Sinai. The babies that we would scan are the preterm ones, and we have that pre-symptomatic approach, right? So we would be scanning all of our babies less than 29 weeks, and we do have a few cutoffs in regards to the PDA characteristics and the indices of pulmonary overcirculation. We do rely a lot on the PDA diameter on itself. So the PDA diameter is usually one of our hard cutoffs, and we use the measure of 1.5 millimeter. But this is a personal practice. And again, as I navigate my way in the hemodynamics practice, whenever I do have a baby that I have that initial measure of 1.5, I don't stop only there to say, what am I actually going to do? I do go over all of the other measures, and I try to make an assumption, okay, am I seeing the significant pulmonary recirculation? Am I seeing the signs of systemic still? And usually they do correlate. Like if I have a duct that it is pulsatile, it has that quite high gradient between the systolic and diastolic velocity, and a size that is usually more than the 1.5, I will also find it's rare when those two things don't correlate. So I think that that's the moment where you start really to analyze all of these things together. They would usually manifest themselves at the same time. At least this would be my view, but I don't know how if you would see it in a different way.
Yeah, I agree. I think in term infants, they present with signs of huffing and puffing because they develop very quickly a LA overload and they have backup into their pulmonary vasculature. And so they become, polypneic and having respiratory symptoms. And, um, that is on its own an indicator that this duct in the term baby is probably very problematic and needs an earlier closure. And then for those treating these patients, there's obviously genetics that needs to be involved and eventually, work up for potential some of these perinatal infection transmissions that can lead to ductal persistence in interim infant. So another question that is quite interesting, well, it relates to some of the results that you've outlined and that you've observed in your practice, um, which is related to how would you explain whether the management approach has resulted in the reduction of IVH, by which pathophysiology, was there concomitant other elements in your bundle that you have implemented for the audience to think about if they would want to reproduce a similar effect in their population?
Good question. In regards to bundle, we do have pretty much similar to many centers, a quite systematic approach to respiratory support, which babies will receive surfactant, which babies will not, who will be intubated, who would not, and similarly to criteria for extubation. As far as I remember, and I can see Federica in the audience, and Federica, you can jump in if you would like. As far as I can remember, there were no changes in that practice. But in regards to the pathophysiology, it would be related to the pulmonary, sorry, to the cerebral ability to auto-regulate in the presence of the shunt. So that was the physiologic rationale for the for this uh, for this practice. But I would like to, I don't know if Federica, if you are available to also do some insights there.
Yes, I am.
Yeah.
Yeah. Yeah, there was no other policy that was implemented at the same period. Of course, I mean, all the units are on a constant growth in terms of how we treat these babies. So I'm not sure about, for example, if the nurses were more trained or all fellow staff and everyone was following the procedures better, but there was no other implementation that was performed at that period. And yeah, as you mentioned, the rationale through the PDA treatment is to rebalance that situation where you have an hyperperfusion state in the first days of life, where you have initially a low blood flow to the brain, and then the PDA might cause an important increase of the flow. So having a first hypoperfusion phase followed by an hyperperfusion phase.
Thank you. Maybe we'll take one last question. We have many great questions, but some of the questions are related to the timing and the markers that are used in some of the scoring system. And I know this is like kind of the $1 million question, but if you would have to assess a patient at different time points during your, the evolution of this baby, I think you start at 24 hours in your own protocol, but are these markers still necessarily reliable or appear in different shape, fashion, severity as these patients grow? So for example, LA dilatation, does it take time to occur? Pulmonary venous velocities, if you start to have pulmonary vein dilatation, will the velocity starts dropping? So kind of like the relationship between the echo assessment and how do you put the package together when you see these patients at different time points in your practice?
So what we do here at Sana, because again, it is a pre-symptomatic, our approach is to scan the baby preferably in that immediate window. We do consider early up to 96 hours, so that's where our early still falls in. If there is a doctor that's present, we do have our treatment protocol, and then we would follow the treatment protocol and the rescanning after that. If there is no duct, or if it is a restrictive one, pretty much it would close itself, like the protocol would end there, and we would only rescan if there is a concern from the clinical group. So then we would, if the duct reopen for, again, as we mentioned, pulmonary cytokines or inflammatory cytokines that are circulating and the duct does reopen, it would be at a later stage when we already are seeing symptoms. We still use the same parameters. I think that the caution that I would have would be as a 27-weeker turns into a 36-weeker, like the remodeling that you mentioned that happens there. We do have the parameters for the LVDD that changes over time, but the for regards to gradient of velocity, and the other parameters, at least in our practice, we would still be using the same.